Today's full talk will focus on current HIV research among Latino, gay, bi, and queer men communities across the US, including here in Chicago. Um, I'd like to share a bit about who we are. By the way, my name is Pedro Alonso Serrano, and I am the co-founding president of the Chicago Queer Latin Collaborative. We call ourselves CQL or CQL for short. We're a 501c3 nonprofit organization based here in Chicago. We focus on health promotion as well as health resource navigation through our primary program, the Prepárate Prep for You and Me campaign, and its accompanying AI powered chat buddy, which is a conversation tool that assists clients in identifying relevant resources. We also have two media forward, media driven um, programs that we're now sponsoring. One is a podcast named The Papiverse, in which is a co-hosted YouTube podcast on social cultural issues pertinent to communities of Latino, gay, bi, queer men in the US. Um, Podcast is bilingual in English and Spanish. We also have a reading club hosted by Paco Gutierrez. He leads this out of Puerto Rico, but actually has participants that participate virtually across the US. Um, have recently completed their first three reading cycles, which essentially means they read three full books together, written by queer Latino authors featuring queer Latino stories. And so that's who we are and some of our programming work. We also, of course, engage in a broad array of research on Latino health, which we will have a series of speakers today um, presenting on their body of work, including, and so I'll do introductions for our speakers, including Dr. Edward Alessi, Professor of Social Work at Rutgers, Dr. Walter Gomez, Assistant Professor of Social Work at UIC, University of Illinois, Chicago, Dr. Gabriel Robles, Assistant Professor of Social Work at the University of Southern California, Dr. Carlos Rodriguez Diaz, who's a Professor of Community Health Sciences at Boston University, Dr. Emma Sanchez Vasno, Professor of Public Health at the San Francisco State University, and the last two, Dr. Carlos Aldana Ochoa, Assistant Professor of Medicine at Emory University, and Dr. Haritha Shah, Assistant Professor of Medicine at University of Chicago. So thank you to our speakers who joined us today. Now, in regards to what has called us here today, not only is this our first, sort of our inaugural end of year webinar, but it comes on the publication of a new report by Dr. and Professor Vincent Ramos at Johns Hopkins, in which he's now described the HIV epidemic among Latino, gay, bi, queer men as a cascading disaster. Why? Why a cascading disaster? Well, between 2010 and 2022, there's been an overall 19% decline in estimated new HIV infections nationwide, which is something to celebrate. However, in parallel and at the same time, as visualized in the chart in the bottom right corner, there's also been an estimated annual new HIV infections among Latinos increased by 12%. And so we see a complete opposite progress in regards to our fight against the HIV epidemic among Latinos. Some of the escalating inequities which have led to this cascading disaster include specific annual new HIV infections among Latino men who have sex with men have risen by as much as a quarter, 24% in these same years. And it's estimated 95% increase in new HIV infections among young Latino MSM, those between ages of 25 and 34 in the same time frame. When we look at new diagnoses among transgender Latina women, this has increased nearly 100% uh, in a similar time frame. Three core drivers or drivers of this systemic failure include Latino invisibility within the broader HIV epidemic, false narratives around what both drive new infections as well as what may also support prevention, and broad societal inaction for example, failure to fund prevention programming at adequate levels or appropriate levels to address these inequities. And so I bring this report to you, findings from this report, in regards to frame our talk for today and help us understand why, this excellent cadre of scholar practitioners and clinician scientists are engaged in the body of work in which they are. And so with that, we'll move straight into our first talk. But a couple points. Feel free to share questions in the chat box, and we'll ensure to address each of them. We'll also hold thanks and acknowledgements for the very end before we move into our open discussion.
Hi, everyone. I'm Edward Alessi, professor at Rutgers, and I'm working with Gabriel Robles, who will introduce himself shortly. Thanks to Pedro for having us present today. Gabriel and I have been working on the Health Journey study, which is a mixed methods examination of prevention behaviors among Latino men who have sex with men born outside the U.S. We can go to the next slide. Uh, so thinking about this cascading disaster, we've been trying to understand some of the within group differences among the Latino gay bisexual men who have sex with men population. And our study, which we started last June, aims to look at Latino migrants as a key population of interest, and particularly those who have recently arrived. And we had started the study with a focus on those who were here less than 5 years, and recently decided to add another group of those who have been here 6 years or longer to look at differences between those groups. And Carlos Rodriguez Diaz is also collaborating with us on this study to look at the persistent social and structural inequities that drive HIV vulnerability, particularly when it comes to migration and the individual interpersonal community and structural factors that shape it. We've been very interested in things like insecure immigration status, economic precarity, housing instability, and of course, intersecting stigmas. We're also looking at pre and post migration trauma and other mental health issues. And part of what we're doing as well, because it's a mixed method study, is also trying to understand the current context since the new presidential administration began in 2025, and how that may impact things like social integration, social support, language access, and of course, community connection and healthcare access, which there are concerns may decrease or there may be more barriers. And I'll hand it over to Gabriel Robles now to talk about the aims of our study.
And so the project is there's kind of three phases for this project, and they're all kind of connected and they kind of build off each other. So first we start with an online survey. It's to understand which factors related to community, relationship, and individual level risks and prevention as among Latino men. And as Dr. Leslie said, we're hoping to look at some key differences or similarities between immigrants who have come here recently versus those who have been here for a while. And then we're going to go a little bit deeper and interview 50 of the men who took that survey online. And these interviews are going to help us understand some patterns that we can see as it relates to the provision of PrEP services, how people are getting on PrEP. And these interviews are already, they've already started, and we're already starting to see some key differences between the early immigrants and we're about to start interviewing people who have been here for longer than 6 years. And then finally, we're going to shift a little bit and look more about the healthcare practices. We're going to interview healthcare providers, and our goal is to understand, what is working well with regards to the provision of HIV prevention services with immigrant men, what needs to kind of get better, and what are some things that we can do to kind of help facilitate the provision of particularly PrEP services for migrant men. And so as a whole, these aims kind of look across individual experiences, relationships, communities, and healthcare settings, which is important so that we can, build effective and, culturally responsive interventions for these men.
Thank
Well,
you.
thank you. I did move your thank you slide to the very. We're going to do a group thank you. Um, so thank you so much for sharing about the health journey study. I'm sure we'll have additional questions for both of you as we move forward, and we're going to call on Emma to speak next.
Hi, everyone. I'm really excited to be here today and to listen to all the presentations and hopefully have an interactive conversation about this topic. Thank you, Pedro, and the whole CQL group for putting together this webinar at this very critical moment. Our project is titled Hermanos de Luna y Sol, or Moon and Sun Brothers, a community intervention to prevent HIV. And before I start, I wanted to mention that Dr. Rafael Diaz, who is an emeritus professor at San Francisco State, is really the principal architect of this intervention. Hermanos de Luna y Sol has been in place for many years. However, it was never thoroughly evaluated for its effectiveness. And so this is the key purpose of our project at this time in the intervention's history. So next slide, please. Hermanos de Luna y Sol is funded by the National Institute of Mental Health, and I'm the principal investigator. As you can see on the slide, we have a robust research team that brings together a wide range of expertise from social epidemiology to biostats, community outreach, HIV prevention, as well as bicultural and bilingual skills. And we are very fortunate that CQL is our community partner on this project. Next slide, please. The population for this study is also immigrant, Latino, gay, and bisexual men. We are programmed to begin the community intervention sometime in February, and the intervention will be delivered in Spanish. The study will compare changes in HIV risk behaviors between the intervention and the control group, and we will also examine changes in self-esteem and social support, as well as the degree to which they mediate the relationship between the intervention and the sexual risk outcomes. Next slide, please. We plan to recruit approximately 180 participants for each site, the intervention and the control. The intervention will happen in Chicago, and it will focus on enhancing social support, belonging, self-esteem in Latino gay identity and community contexts. We also aim to improve sexual self-knowledge and to promote critical awareness of the social cultural forces that have been mentioned in the previous two presentations. And of course, facilitate community involvement to enhance community support. Next slide, please. And I'm now going to turn over to Pedro to join me in sharing some of the work that CQL has been instrumental in doing.
Well, thank you, Emma. In partnering on this, kind of historical intervention of the Hermanos de Luna y Sol program, CQL's been able to partner with San Francisco State University academic team on really the broad protocol, but specifically in the areas of co-designing the marketing materials for recruitment, um, updating the intervention manual substantially for more of a contemporary approach. The intervention was originally developed a couple decades ago, and so it's we felt it needed some refreshing, and including the inclusion of biomedical HIV prevention approaches as this intervention was pre the PrEP era. And even in the intervening years, of course, we now have new PrEP products such as Yestugo and such. We've also worked on translating and interpreting the manual from English to Spanish so it can be completely delivered in Spanish. Some particularly interesting social cultural intervention activities including culturally responsive activities for the men who will be participating, including the use of Loteria popular game for the purpose of sexual health education, as well as incorporating what is known as the Mapa de la Vida, which is essentially a journal around not social experiences, health experiences, sexual health journeys, and encounters for the purposes of reflection. We have already conducted mocks of the intervention, both in English and in Spanish, in order to ensure that the team is ready to deliver the intervention. We're continuing to fine tune and revise the manual based on these mocks and based on feedback. We're now moving into pilot testing our full data collection management platform, which we're using Qualtrics for to ensure that everything works as intended. And so we're excited to move along on this particular project. And that's Hermanos de Luna y Sol, and so I'm going to ask Haritha to jump in.
Great. Hi, everyone. And thank you for allowing me to speak today alongside each of you. This is such a nice way to sort of end the year and otherwise very crazy time. All right, so again, my name is Haritha Shah. I'm an assistant professor at the University of Chicago. I'm a primary care physician in internal medicine and pediatrics, so I see adults and kids, and my research has mainly been in public health approaches and community engaged research to improve equitable access to preventive care, especially surrounding PrEP in Latino and Latina communities. You can go to the next slide. And so I've been fortunate enough to have worked with CQL since 2020 when I first joined the faculty at University of Chicago. And we, at the time, had sort of joined forces to launch this campaign called the Prepárate campaign. So this was a community-driven social media and in-person marketing campaign designed to improve awareness of PrEP and access to local PrEP resources. It was very much grounded in the foundational work done by a lot of the people on this call, even years before I was able to join with them. And so we were able to launch this campaign in 2022 and had reach over social media, various social media apps, public transit, in-person community events, and recruitment. And as you can see, it was all based on qualitative interviews featuring local recognizable Chicagoans and really meant to be a celebration of health and positivity. And we still have this website going today, the Prepárate website, which Pedro had also mentioned earlier. We can go to the next slide. So some of the so we had evaluated this campaign back in 2023 or so and found that it had overall a great reach and a pretty extensive reach tailored to the Chicago region. We had good success over TikTok, Facebook and Instagram, and more over Grindr. And we had done some surveys to understand like who were we reaching with the campaign, but who also might we be missing? And overall, we did see good initial pilot results. So about a third of people we surveyed had seen the campaign, and for those folks who had seen it, you can click once more. Sorry for the placement here, but basically those who had seen the campaign were significantly more likely to be aware of PrEP and to actually have used or started PrEP. Right. And then we sort of looked at how, this might be affecting people at various stages of considering PrEP. And it seemed to be, people who had exposure to the campaign were more likely to be on the side of preparing to use PrEP and or actually starting it. Next slide. So we did a mixed methods evaluation. We did some qualitative interviews with community members, but also members of CQL and all the different stakeholders who had a part in this campaign. And overall, noted many strengths. It was well received. And we also noticed some potential gaps in who we were able to reach in that pilot period. So there was a lot of interest in like deepening our reach to youth. We also had a limited reach to Spanish-speaking immigrant populations, especially older populations. And also the campaign was not tailored to cisgender women. And so these were some potential future directions. And then we also certainly needed to complement this by studying the social determinants of health and the climate that were affecting how this intervention was received. Okay, next slide. So that brings us to the current project. We're fortunate enough to receive a K-23 grant, which the goal is really to just build on the success of Prepárate and our ongoing community academic partnership, which I'm so fortunate to be a part of. So we do want to deepen that focus, including our outreach to young adults, which, as Pedro had mentioned earlier, is like definitely a priority population right now, and also our reach to Spanish-speaking immigrants and the overlap, obviously, of the two. We are currently working on the Conectados surveys, which are meant to do a social network analysis or studying the social networks of young Latino or Latina gay, bi, queer men and understand how those social networks impact PrEP use, and honestly to think about how we can augment Prepárate to better reach those groups. So through some sort of social network or peer-based intervention. And so hearing the work from Dr. Alessi, Dr. Robles, and Dr. Sanchez-Vazno, I think we have a lot of overlap. So I actually certainly am excited to see your results and potentially share, and of course with the people who are about to present. So that's currently where we are right now. We're in the middle of these surveys, and we're also starting to do some qualitative interviews with this group to understand how we can build on our existing model and add some sort of in-person or peer or family outreach. And also working on this AI chatbot, the Awesome Buddy, and seeing how that can help with tailored navigation, even during hours where our HIV hotline or may not be available. Long term, we are certainly hoping to collaborate even across cities. So I think that this is a great place to start. Thank you.
Thank you. Next is Carlos, and Carlos,
Hello,
let me know.
can you hear me?
Yes, let me know if you want me to exit out of this and let you share, or if this is fine.
You can, I think, yeah, we can exit. I
Oh,
don't have
okay.
any slides. Yeah,
Oh,
and I'm
well, then
also
I'll just.
surprised. I am also surprised that it's SQL. It just clicked that it's SQL, the CQL. So,
CQL, sequel.
yeah,
Yeah,
SQL. It's
there's a story behind that it's the sequel to a prior organization, but so I'll just keep it on here then, and you can go ahead.
Oh, okay. So, hello, everybody. My name is Carlos Saldana. I am an assistant professor of medicine at Emory, and my group specializes in HIV work for the Latino community. In 2024, we launched a citywide peer navigation campaign. We have a human peer navigator that would be contacted via Instagram, Facebook, WhatsApp, and he would help the community um, access convenient services depending on their circumstances. We found that this program was acceptable, was feasible, was effective in linking community to a variety of services, HIV care, HIV prevention, doxypep testing. However, we started seeing that the after the fact, the referral portion still needed some work. We're still here in the city of Atlanta, don't have enough providers that are bilingual. We still have the community that is segregated to the northeast of the city, far away from public transportation. So Salud Mobile emerged from some of these experiences. So to give you an overview of what Salud Mobile is ramping up bilingual telemedicine and bundling it with mobile testing and phlebotomy that is designed for and by the community. So this project is a year one that has been funded through CDC. It has two phases. The first phase of this project is to conduct in-depth interviews with providers and community and asking them how would telemedicine that is bundled with mobile phlebotomy and testing should look like. What are things that we should be considering? And we have met with 30 providers, with 30 people in total, 15 providers and 15 community members to ask them these questions. And we've learned a lot. We completed all those interviews, and I've been reading through these transcripts. I read them. I read them when I have some spare time. But I wanted to share with you some of the lessons that we've learned from these providers as we plan for phase two, which is the actual implementation of this project. So people like this bundled intervention. They like collapsing this already fragmented healthcare system that we have, in which we have to go to the provider for a visit, then for laboratory, and maybe for picking up our medication frequently. So they like that mobile integration. We learned a lot about the importance and how privacy needs to be built into this intervention. We heard from community and providers that these vans and outreach vehicles need to be unmarked, that people would like to meet in locations that maybe sometimes they feel comfortable bringing in healthcare workers into their home for laboratories, but sometimes they have immigrants live, maybe people may live with multiple roommates or may not feel comfortable disclosing it with their family. So having that flexibility of meeting maybe in a convenient spot. We also learned that telemedicine may not work for everybody. Some people may want to keep the in person. Some people feel more comfortable seeing a doctor or may trust somebody on a direct face to face interaction. We learned that navigation is important, that people need that extra bilingual support, especially if we're doing telemedicine, so people don't feel comfortable or don't feel technologically capable yet. So having that extra support into how to access this services and how overwhelming the U.S. navigation system can be. So having that bilingual person that can help you know where to go and how to register for Ryan White or ADAP, etc. So that is really important. That language is non-negotiable for your phlebotomist, for your provider. They have to be bilingual. Another thing that we learn about the mobile services is that it has to be high quality, that it cannot be just an outreach. People want to feel like if you're going to offer this service, that it has to be clean, that it has to be professional, that it has to feel like they are in a clinic so they can feel safe. We were asking about the newer modalities of prevention and treatment with long-acting injectables. And the main thing that came up from these interviews is that people don't know about them. So what else can we do to increase education about long-acting modalities, because we could use these technologies to deliver long-acting injectables for prevention and care to people's homes. One thing that was really interesting to me is this theme of reframing, not adherence to uh, and to a design failure. That if people are not able to follow up with our services, it's because our systems are not adapting to their busy lives. So being able to offer appointments that are over the weekends or late at night or maybe early in the morning before the shifts of people is really important. We heard that telemedicine is an important trust building tool. As you may know, people are not leaving their houses in this current social political landscape. So, how valuable it is to be able to meet with your doctor through the comfort of your home. So, we're hearing that it enhances the trust and makes people feel safer. And finally, I think something that is coming up is that I'm often thinking of sexual health, but people also want, once HIV becomes controlled or once I feel safe taking my medications, I want to know more about vaccines, diabetes, hypertension. So, how can we bundle these interventions to provide comprehensive primary care? So, stay tuned for some outputs that we will be submitting to H26 and the Ryan White Conference of this work. And most importantly, we will be designing and piloting this intervention at Grady Spons de Leon Clinic here in Atlanta. So with that, thank you, Pedro, and the CQL team.
Thank you. So excited about your work. And so I think Dr. George Green at Northwestern had been invited to present his MARI study. This was a part of a CDC program, similarly funded. Carlo's work. George unfortunately was unable to join us. However, with CQL being the community advisory board for his study, he asked that I present briefly. He had more extensive notes, but I'll share some brief notes on his study. The formal title is Understanding Medical Mistrust to Inform Adaptation of an HIV Prevention Intervention. We've given it a more of a familiar, community-friendly name, project name, which is LUCES, Latinos United in Community Education and Support. I'll share some background on this study. In regards to the objective and aims, so the objectives of this particular study is to collaborate with our local health department, the Chicago Department of Public Health, as well as community-based organizations such as CQL and others in our collaborative to reduce HIV infections among Latino MSM by developing a culturally responsive intervention to improve engagement in PrEP healthcare services. Our aims include to aim one, to better understand medical mistrust as a social determinant of health, from the particular perspectives of both Latino MSM, HIV healthcare providers, as well as social service providers. This is the work that we're currently involved in. The team at Northwestern has been, well, the CQL team has been recruiting individuals for the interviews, and the team at Northwestern has been conducting the interviews, and we were actually far along on completing AIM 1 at this time, of which I have some preliminary findings to share with you. AIM 2 includes to select and adapt a CDC EBI for Latino MSM using the adaptant model to specifically address medical mistrust, health misinformation, PrEP healthcare engagement, and also leverage implementation science frameworks to optimize intervention delivery. Finally, the plan is to conduct an implementation feasibility trial of the particular adapted intervention, of which we've not yet selected one. There's an overarching framework for this particular study. I won't walk you all through it, but the idea is that we're adopting an anti-racist in health framework to particularly address medical mistrust, which is in some frameworks, not an element that is examined, but which we feel has been, a critical gap. So some preliminary findings from interviews with providers, and this is just a brief summary of findings. Providers agree that mistrust is real and it's justified. It's a justifiable concept, not just a theoretical argument. They see it most in patients who are new to the United States, who mostly speak Spanish, or who also face other strong stigmas around their sexuality, their sexual orientation identity, their sexual practices, sexual behaviors, sexual attractions. Mistrust directly leads to patients not getting the HIV prevention care they need, including PrEP, meaning potentially avoid HIV testing, which means avoiding HIV education, HIV counseling, which would lead to, potentially a discussion around PrEP. So mistrust really intervenes at the very early stages of accessing health and health services. Future interventions, we hope can help reduce mistrust by working with trustworthy peers, peer navigators, peer educators, peer counselors, being honest about medication effects, meaning, just to name a couple examples, what are the expected side effects of going on Truvada, Descovy, Apretude, Yeztugo, etc. Protecting confidentiality and making it easier to access services. For example, to some of the points that Carlos mentioned around, there are folks who work first, second, third shift, meaning the typical 8 a.m. to 4 p.m. clinic schedule, which you need 3 months in advance to book or longer, really may present serious barriers for folks that have to come in early, late, or only have weekend availability. And so these are some findings from George's work, which we hope to see more of as he moves forward. And with that, I'm going to call on Walter to continue our talk.
Hi, thank you so much for having me. I'm going to provide a brief presentation on a study that I'm currently working on. Given the status of the enrolling process, I'm going to be focusing mostly on some background that motivated the study. Next slide, please. So even though we had a little bit of background about the current situation regarding HIV and the Latinx community in the US, it's important to recognize that in Chicago specifically, about a third of new HIV diagnoses are among Latinx individuals, and a lot of the literature points to the fact that stigma is oftentimes cited as a driver for HIV infections among this population, and there have been some recent efforts to address these outcomes from an intersectional perspective. When you think in terms of substance use in the Latinx community, it's important to recognize that is oftentimes framed by experiences of multi-level and intersectional stigma. Given that intersectional perspective, research suggests that Latino sexual minority men are likely to experience compounded stigma given their interlocked identities, which have been historically marginalized. So this may lead to problematic substance use and less potential to be able to forge healthy bonds and relationships with members of both the LGBT and the broader Latinx community. Moreover, substance use oftentimes serves as a coping strategy for these communities, specifically in the absence of resources that may help to address these negative effects of stigma. Next slide, please. So there's now I want to talk a little bit more about methamphetamine, specifically in the context of sexual minority men. So there's a lot of literature that shows that methamphetamine use produces a lot of negative outcomes across several life domains, and some of these outcomes are specific to both HIV prevention and care. Traditional literature mostly focus on methamphetamine use preventing more traditional means of HIV prevention like condom use, but there's also a lot of literature that suggests that it also impedes effective engagement with PrEP. In fact, some of the early trials intentionally excluded methamphetamine and other substance users from activities given stereotypes around their capacity to engage in these structured behaviors. There's also a lot of literature that suggests that there's a lot of negative outcomes when it comes to those already living with HIV in terms of medication adherence and also accelerating HIV biomarkers in these communities. So, sorry. Um, so research also suggests that sexual minority men typically engage in meth use in order to facilitate relations with peers and also to enhance erotic experiences. Nevertheless, these potentially positive outcomes usually come at the cost of disruptions across several life domains, as I already mentioned, but specifically psychosocially, they have to do with outcomes such as suicidality, mood disorders, and relational conflicts, among others. Similarly, psychological and structural stressors have been shown to support both the initiation and the prolongment of methamphetamine use in the broader sexual minority men population. Some emergent data, essentially part of the research that I conducted back in San Francisco, suggests that feelings of disconnection are typically associated with meth use, as well as sustainment, as well as hindering recovery efforts in the broader population of sexual minority men. On the next slide, I'm going to talk more specifically about Latino sexual minority men and meth. Specifically, there have been recent reports both globally and in the United States that suggest that there's been an increase in methamphetamine use in the general LGBT, or rather sexual minority men population. Even though there have been a lot of success in the early odds at reducing methamphetamine use, the past few years have shown an increase in meth use in the broader queer population. But there have been some data that suggests that these increases are also disproportionately impacting Latino sexual minority men, again, seemingly driven by the aforementioned intersectional stigma, as well as other synergistically occurring adverse events. However, there is a dearth of current data relevant to drivers and context of use among Latino sexual minority men. In fact, Dr. Rafael Diaz from San Francisco State and San Francisco broadly was one of the original proponents of some of the data relevant to this population. But as you can see, it's been a few decades since there have been intentional focus on methamphetamine use in this population. And something that's important to note from these data is the fact that beyond the social and sexual motivations for methamphetamine use in the broader sexual minority men population, when it comes to Latino men, they also cited that stimulant use, specifically meth, supported work-related and labor-related behaviors, which is something that was very specific to this population. So a lot of us know that HIV research and methamphetamine use have been inextricably related since the early days of the epidemic. So we need to invite more integrated approaches to better address these increasingly negative health outcomes in this high priority population. And on the next slide, I'm going to speak briefly as to how I'm hoping to support these efforts. So essentially, I was funded to run a small exploratory qualitative study by both the UIC Institute for Research on Race and Public Policy, as well as my college, the Jane Addams College of Social Work. And what I'm trying to do with this study is better assess the role of synergistic psychosocial factors that promote meth use and hinder recovery efforts for Latino sexual minority men in the context of Chicago. I feel like context is really important because traditionally the literature on meth and sexual minority men has been located in coastal settings like San Francisco, Los Angeles, New York, and Miami. Specifically, I want to focus on both relational and structural factors that inform these use behaviors and may hinder recovery efforts. The study is framed by intersectionality, syndemic, and revised stress and coping theories, and I'm using a constructivist grounded theory methodology to design and analyze the data. Like I mentioned, I'm still in the process of enrolling for this study. I actively began this back in the spring of this year, which unfortunately coincided with this new administration's inauguration. So it was very difficult to make connections with community organizations, given that they were under threat of having their their funding and functions being cut. And similarly, when I started a second wave of recruitment over the summer and fall, that also coincided with federal intervention in terms of immigration here in Chicago, which increased this population's willingness or capacity to engage with institutions. So out of a proposed 20 men that I want to enroll, I've so far only been able to interview 3 of them. So I have screened 15 and only 4 became eligible, and one of them ended up like not showing up to the interview and responding to follow-ups. And in the interview guide, I essentially want to learn more about their process of identity development and how that has been informed by relational factors across diverse domains, so ethnicity, sexuality, etc. I also want to learn in terms of how culture impacted their engagement with their lived experience based on these behaviors, as well as other relational factors, and looking also specifically at the role that physical spaces have and how they're able to engage with diverse activities. So essentially relationships to spaces that cater to the Latinx community, to LGBT community, and perhaps both. And then specifically look at their histories of methamphetamine and other substance use and how they have been informed by the aforementioned domains, transitioning into broader information on HIV and health, and wrapping up that those narratives and conversations. So hopefully as the study and the recruitment progresses, I might be able to help support in filling these gaps relevant to meth use in this population, how it further informs engagement in HIV prevention and care. Thank you so much.
Thank you, Walter. We'll move straight into the last speaker.
Great, thank you, Pedro. Good afternoon, buenas tardes. Always a pleasure to be surrounded by so many brilliant people, and I'm delighted to share with you briefly some of the work that we're doing on structural interventions and capacity building. So next, I want to make sure that we have time for conversations at the end. So first, I will share work that we are currently doing in terms of structural intervention to improve HIV outcomes. I will briefly share the work that my colleague Omar Martinez have been leading for several years now, and that we continue to implement on medical legal partnerships. And then I would share with you for the first time findings from a study that I've been conducting over the last few years in Puerto Rico and Washington, D.C. on institutional practices for PrEP implementation. Next. So medical legal partnerships are very well known as a practice to improve health outcomes. And medical legal partnership basically means bringing legal services to health services. Omar Martinez, a pioneer in bringing medical legal partnerships for Latino, to improve Latino health outcomes, specifically for sexual and gender minorities and for people affected by HIV. We are now not only demonstrating that it's feasible to bring legal services to primary care services and HIV services, but for the first time, we have a randomized controlled trial to demonstrate the effectiveness of medical legal partnerships to improve health outcomes. And now, if you look at the literature, we have documented in several instances how bringing the legal services to the primary care services or HIV services is being associated to improve HIV outcomes among the people who receive the services, but also have supported the development of infrastructures within organizations to improve the services that are provided to our communities. So this is changing the landscape, not only for the improvement of HIV outcomes through structural interventions, but for medical legal partnerships overall. Something important here that is a bridge to the work that I'm going to present next is that even in the services where we've tested medical legal partnerships for the improvement of HIV outcomes, we see that higher numbers of on-site services are also correlated with improving HIV outcomes. So what that means is that it is not only about the medical legal partnerships that are being implemented, but also other services, wraparound services that we are providing for the people affected with HIV. Next. And over the last 3 years, I've been focusing much more on PrEP implementation. And I've been inspired not only by the fact that PrEP implementation hasn't been great among Latinos, but the fact that over the last few years, I've been doing work in Puerto Rico, as I have historically done, but also in other settings in the continental US. So I implemented a study that focused on PrEP implementation in San Juan, Puerto Rico, as one of the jurisdictions that are prioritized by the EHE initiative, and also Washington, D.C., which is another prioritized jurisdiction. And what is different between these two jurisdictions is that Puerto Rico has the lowest PrEP uptake of all the jurisdictions in the United States, and Washington, D.C. has one of the top two PrEP uptake among all the jurisdictions. So very different scenarios, but however, in both, we were having Latinos who were engaging in PrEP. So because I got tired of identifying what is not working, I decided to focus on what was working. How is that even in the case of Puerto Rico, where we have really adverse circumstances for PrEP implementation, we have people on PrEP. And in the context of Washington, D.C., where it seems like we have several resources and something is happening that is working for most people, we also had Latinos engage in PrEP. So with that approach, we conducted a mixed method study where we interview providers of PrEP services for Latino communities and Latinos who were either using PrEP or were eligible to use PrEP. We also conducted a survey among providers of PrEP services. And what we found was the three main areas that are illustrated here. First, that a core element for PrEP implementation, for successful PrEP implementation, was good healthcare encounters. And healthcare encounters were particularly successful when the providers were competent, meaning that they knew about PrEP, they knew about other services that people may need. They also were good communicators. They were asking questions to their patients. The patients felt comfortable with the questions that they were asking, the way they were asking questions. And providers were able to relate to their patients in a way that the patients felt related to their providers. Patients explicitly share how important it was when they found a provider that spoke Spanish and Spanish was their first language, or when the provider also revealed that they were using PrEP, or it was a trans person or a sexual minority person that helped in facilitating engagement in PrEP. We also identified that having wraparound services that were not limited to HIV prevention enhanced the likelihood of people engaging in PrEP services. And lastly, we looked at the institution, what people had to say about their institution, what patients had to say about the institution, but also if the institutions that were being successful or not in the implementation of PrEP had specific guidance. And what we documented was that, of course, if an organization have clear policies and practices, are more likely to be successful in PrEP implementation. But it was not only the fact that providers were able to document this and they share the experience of how better it was working when they had clear procedures on how to implement PrEP in their services, but patients also notice the fact that the clinics or the services were organized and it was clear for them how to navigate the services. And lastly, and has been shared before, telemedicine is changing the game for access to care. We know that is not for everybody, but for those who could benefit from telemedicine, it is helping in engagement and retention in PrEP care. Similarly, geographical accessibility. And this was true in both jurisdictions. In the case of Puerto Rico, as we focus in San Juan, we had people coming from non-metropolitan areas to get services. And historically, we have documented that in Puerto Rico, but now we have more clinics outside of San Juan, and that is helping. And the same for Washington, D.C., where we have people from Maryland and Virginia that comes and get services in Washington, D.C. So telemedicine, both, and transportation, and being geographically located near where people live, we're supporting the PrEP implementation. And next, and lastly, I want to mention the work that we are doing through a R25, a grant that we still have from NIDA to provide capacity to undergrad or recently graduated students who are interested in HIV and substance abuse research. Next. So the program is called CHAIR, and Scholars in HIV/AIDS Research and Education. This is a program that we started 3 years ago while I was still at George Washington University. We have completed 3 cohorts, and here you have the beautiful pictures of the colleagues that have gone through the program. I'm very proud to say that a third of them are now in grad school, from PhD programs in sociology to masters in public health. And we also have a third of them that are in the workforce, and all of them are doing HIV-related work, either in a combination of clinical and research work, and others are providing services in organizations that are providing services, including community-based organizations. Next. This is a general description of the program. We have lectures. All of them are matched with a peer mentor, a career mentor, and a research mentor. And with the research mentor, during the summer, they work on a specific project that they then present at the end. I'm glad to say that I've had 3 mentees over the 3 years, and we have 3 papers under review right now of the work that they have conducted. They have used real-world data, in my case, data from my own studies, to do sub-analysis, and it's been a fantastic experience. I know that many of you have been invited to give talks, so I am very thankful of your contributions to the program. And next, we are currently recruiting the next cohort, and this is the information I believe that I have shared with many of you, but if you are interested, I'll be happy to share more information. I would share my email in the chat in case you want the promo. I have also shared it on social media. But we now we had to drop the name Latino Chair Program because it was unfortunately a way of keeping the program funded. The program is not limited to recruited Latinos for the internship. However, so far, or the participants have been Latinos. We need to invest in the pipeline, and we need to start early in bringing early career scientists who are interested in their communities to know more about HIV, the exciting work that we can do. It's been a phenomenal experience, and I hope that we continue to do so. And we need your support in spreading the word so we can recruit talented people that will do the work that we're doing today in just a couple of years. So with that, I'll stop. Thank you for the opportunity to present.
Thank you, Carlos. A couple quick notes. Well, one, we for all the work that was presented here that is federally sponsored by CDC and NIH, we just wanted to acknowledge that, all of what we've shared is from our own opinions and work, and not the views of the federal government. Also, thank you to all of our speakers. I've listed their emails here in one slide. This slide deck and recording will go to all registered per Zoom. Also, this call is scheduled for an additional 15 minutes for anyone that wants to stay and ask questions of those who also can remain. So we have a couple more minutes to, because we went up to our time, but I had some planned questions, but I think instead of doing that, if there are any questions from those in attendance of others on the call, I think we can just open it. And feel free to take yourself off mute and just, or you can raise your hand, whichever you prefer. I know there were some questions in the chat from Yuri. I don't know if you want to jump in.
Well, good Good afternoon, everybody. Judy Velasquez here from Pixis Partners. We are a small consulting firm in DC. We do community engagement, advocacy, and social policy. Hello, Carlos. Uh, and so, yeah, one of my questions, I mean, I think that having worked in community engagement and patient advocacy is that when it comes to race, ethnicity, I think it's kind of known, or I mean, there's been a lot of research done with, yeah, if you see yourself in your provider, if you see yourself in commercials or whatever, that helps increase traffic, or it helps, with adherence or whatever. I think that now we also want to, especially in this social political climate, we may need to also just focus on the availability or the access to care, whether it's screening or actually primary care, because I think without medical coverage, you cannot go to the doctor, right? You cannot pay the doctor. You cannot do that. So if there are a lot of barriers when it comes to accessing um, services, that is going to hinder a lot of like community health. Also, I just want to praise the mobile services, the research that's going on, the intervention, because I think, and I put it on in the chat, where a lot of people, especially now, do not want to go out, or they don't have the means to go to, like, downtown or go somewhere. They live in a rural area. So I think mobile telehealth, telemedicine, it's the way to go. But we also gotta just, think about the generational divide, where like the older folks, like, I don't understand my phone. Like my mom. My mom is a perfect example. She hates smartphones. But again, I think it's easier to go the digital route. It's just a matter of making them understand that this is where we're going.
Yeah, a lot of interesting points there. Anyone with a particular question of those who are still on the call?
Yes. Hi, everybody. Thank you for presenting. I'm an undergraduate student at the University of Michigan. For Walter Gomez, I was interested in your work and your connection with methamphetamine use among like Latino sexual minority men. So I was wondering if you could explain to me more about like these substances, how they're used amongst the community, and like in particular relation to like the sexual, social, and work context. And I'm also like interested in more of like the broader issues like prep engagement as well. If you can elucidate on that, that would be lovely. Thank you.
Sure. So, broadly speaking, methamphetamine use, because of essentially what it does to the body and the physiology, tends to disinhibit folks in terms of the sexual practices and behaviors and choices that they're able to make within their use, and oftentimes this leads to developing a very specific sexual life and network that is very much predicated by the use of that substance, meaning that it's oftentimes difficult for folks to, once they go or enter that pathway, to have sex in other different ways or in the absence of methamphetamine. So essentially, it creates those differential bonds. It limits a number of other social and, other experiences and duties that they might have. And in terms of like prevention, like because oftentimes when folks, or especially like guys, use, they become these like marathon events, right? So they can go like a full day, several days, a whole weekend in the act of seeking and engaging in sex, that they oftentimes, if they were, engaging in other types of protected behaviors like prep use or engaging in care, those likely are not part of their focus at the moment when it comes to folks living with HIV. Beyond adherence to medication, it also causes inflammation and accelerated aging on top of what the virus itself does. So those are kind of like some of the main features relevant to how meth impacts kind of like sexual, social, medical, and other domains. So ideally, that helps fill some of those gaps.
Yeah, thank you so much.
Mhm.
Any other questions from the attendants? Well, in the event that there's not a specific question, I had one, as the moderator for this and convener of this group of panelists and speakers, including being engaged, and collaborating with you all on our body of work here. I had a question for the full group, but I think just given, we don't need to go back over it, but we all know what has happened this year, the way things have been going. We still don't necessarily know, what the future holds. But that said, we somehow have managed to stay funded. Um, and my question to you all is, you all represent really examples of interventions across the socio-ecological model, right? Intervening from the individual level up to the structural level. And my question, coming from a community's perspective is, what can we do in regards to academic and applied research to continue to move this needle forward? And um, were there opportunities for collaboration or brainstorming ideas on new ways to move forward that came up from this call? I just wanted to hear if there's any thoughts on that from the researchers on the call.
I'm going to volunteer Dr. Rodriguez Diaz.
Well, so I think you have a couple of questions there. Can you help me focus in on one so we can maximize the time?
Yes, of course. So given what we know of how this year went, and yet we don't know what's coming, what can we do in the now as individuals that, we currently do have access to resources in regards to our funded programs? How can we best leverage that, not just as our individual teams, but across teams potentially?
Yes. So first of all, I want to remind us that we cannot lose hope. I mean, the fact that we are here, that we're doing the work that we're doing is because it matters. And something we have done well, that we have been funded, we have been supported to do our work, and still under very adverse circumstances, we continue to get or have the support that we need. I believe that we will continue to do so. It might be a little harder, but it had never been easy. So we have what it takes to go through this. Secondly, we need to do more of this. We need to work together. I love the fact that I know many of the people here, and I hope that that is also true to others, because we need to strengthen our collaborations. When we have less resources, we should not be fighting with each other to get the limited resources that we have for our communities. And I believe that we have never done that. We've been very supportive. We have been doing well with mentorship. I am happy to see more scientists. As you were introducing the speakers, most of you are assistant professors. That's beautiful. You are the present and the future. When I was an assistant professor, I was quite alone. So it's beautiful to see that we are growing as a community of scientists, and also that we have so many good, talented, committed community partners, because that would make our work have an impact. And as you know, we will identify the ways of navigating this next couple of years. There is a focus from the NIH on implementation science. A lot of the work that have been discussed today is either already using implementation science or in the very near future would integrate implementation science. So all this to say, I think we have been doing well, and we have the capacity to go through this, and we will do well. I am also very happy to see what Vincent is doing by increasing the visibility of the issues affecting our community. He is working a lot. There is a few more things coming up, and it is helping us to create this kind of platform. So again, and it was lovely to hear from Rafael Ayala, Jesus Ramirez Valles, who were mentors to me, who are still in the field mentoring many of us. So that speaks of the history of our community. We will continue to do well, and hopefully we will see the end of the HIV epidemic. So let's keep going and don't lose hope, people.
Thank you so much for that wave of positivity and, remembering where we've been. And yeah, you're right. It's never been easy, and we've continued to stay at it. Um, I felt like that was a beautiful concluding remark, unless someone else has anything they want to say.
I think there is a question in the chat that still is a kind of an extension of what I mentioned. I want to acknowledge that although I'm talking about hope and overcoming challenges, yes, it's been tough, people. It's been a year that feels like a decade. So also, I hope that the next few years, sorry, yes, but the next few days, if you have the opportunity to take a break, be gentle with yourself, do it. We need breaks. We need TLC because it's going to be challenging, but we can do this. It's been, let's not forget that even though we can achieve our goals, the only way of doing that is also taking good care and finding things that makes us happy and brings us joy.
Very much on the boat that joy is an act of resilience.